First, thanks for being here. I'll just give 20 to 30 seconds on the whole background of the Boroff-Forman thing. I endowed this and a series of sort of scholarships and internships for the School of Public Health about 12 years ago after I'd recovered from the first catastrophic event I had. And I've been really happy to be able to have amazing guests that are primarily in the public health and public service space. We've had Zeke Emanuel, who was the White House architect of Obamacare, had Gail Walensky, who's the former Bush and Reagan head of Medicare and White House advisor. We've had just recently Mandy Cohen, but more distantly Vivek Murthy, our nation's current and former Surgeon General. And we've had Jim Brink, who is the chair of the Brigham and Mass General as speakers, and always on topics that are not directly on radiology, that are more radiology adjacent or healthcare topics, health policy topics. I've been fortunate to know Mike Ivey really well over the last several years, particularly through the pandemic. And he is an incredibly eloquent speaker on this topic, and I've been fortunate to hear him speak about it both for my students in my graduate programs as well as on our podcast. He is currently the Deputy Chief Medical Officer of Yale New Haven Health System, but he's trained as a trauma critical care surgeon by background. He began his career in the Navy, spending around 9 years in active duty. He completed a fellowship at Yale in surgical critical care and became Chief of Trauma Burn and Surgical Critical Care at Bridgeport. And at Bridgeport, he rose through the ranks, becoming Vice President of Performance and Risk Management, Chief Medical Officer in 2012, and then President of Bridgeport Hospital in 2018 as interim. He did his bachelor's degree at WashU and his medical degree at UConn. And his role here has been centered on issues around physician well-being and making our workforce more sustainable and healthier, and seeing us all be the best that we can possibly be. And this topic in particular, which you'll address, is one that's very near and dear to my heart as well. I spend at least one lecture a year with my students talking about my own time dealing with mental illness and dealing with suicidality. And I think we're afraid of talking about it too much. And I will say that as we are about 8 days out from a suicide in the first-year class of the medical school right now, it is a time that I think we all should be looking to each other with kindness and making sure that we're reaching out to everybody at every possible time. And so this is a very timely talk. I appreciate you doing it. Thanks for joining us.
You need me to? No, good afternoon, Howie. So just so that everybody's aware, I deeply appreciate the invitation and the opportunity to talk and our friendship. I also want to mention that I want to thank Dr. Goodman. Not every leader is really comfortable having someone come talk about depression, even though it's a real issue that we face as a society. So thank you to Rob as well. Can I just start going on slides? Great. So burnout, I'm going to talk about my journey. I have no conflicts to disclose. I talk about burnout and depression because I think those are, as I say here, the major occupational hazards for clinicians in the 21st century. When I was training, there were a lot of concerns about HIV, which was still very contagious and bloodborne. Hep B, Hep C, in previous years, decades, centuries, it was, TB and things like that, cholera, but now it's burnout and depression. So I'm gonna talk about it and how I got help and maybe make some recommendations about the lessons I've learned. I'm gonna start by talking about why I talk about it. So as Howie alluded to, back in 2019, when I stepped into this role, I knew I was going to be working on well-being. And one of my daughters at the time was an intern at WashU. And so I called, Julie. I said, hey, what are you guys doing about well-being and, mental health support for the residents and fellows? And they weren't doing anything we weren't doing. And there's only so many tools. And so they were, really basically doing a lot of the same things that we were doing. But Julie had what I thought was a key insight. And she said, Dad, when somebody comes and talks about, well, hey, if you're struggling, this is the number to call. If you're struggling, email this person or go to this office or contact so-and-so. She said, nobody ever says, and when I was struggling, this is what I did. And so you don't want to disappoint your daughter. So here I am. Burnout, again, burnout's so widespread in the health system now that it, across the country and frankly, across much of the world, it's almost not really hard not to talk about it, at least for a second. Exhaustion, again, we know from survey data in the middle of the pandemic that, 80% of our staff were exhausted in 2021 and 2022 and 2020. Exhaustion was, everywhere. Irritability. I think irritability is a good sign in people who are not normally irritable. Throw that caveat in there. Cynicism. When I was really burned out, a period that I'll talk about, I was incredibly cynical about what the healthcare system was doing, about the hospitals, about just the system in general. I think that is one of the challenges. I also bolded a sense of reduced accomplishment. You feel like you're not getting things done, like you're not being effective. That is part of, this whole burnout syndrome. Many people, not everybody. I mean, there's a gradient there, but as you get into the deeper end of it, a lot of people feel like they're not being effective in their role. And the really deep end of it, unfortunately, is blaming yourself. You feel like things aren't getting done and it's your fault. And we need to be mindful of that it's part of this burnout. And if you are feeling that way, you need to be mindful of that. This is a pretty good model of burnout. Well, I mean, it's good enough that Stanford trademarked it in 2016, so they must feel it's worth something. Let's start with what I would call work. They call efficiency of practice, but of course, it's not just the efficiency. The efficiency does drive people crazy, right? I mean, it's the sand in your shoes. But it's also the overwhelming volume and the production pressure and the time pressure that everybody feels, which is a real thing, right? Personal resilience is a factor. People don't like to talk about it. I would tell you that if you make it through college, you make it through med school, you're in residency, you get to, we're resilient. You're in healthcare, you're a resilient person. But even within that framework, there are people who are really resilient and people who are resilient, but not as resilient. And so there's more you can do to help yourself. And you probably should. And we'll talk about that some more in a minute. And then the culture. They're like, well-being matters. And that if you're struggling, you should get help. It wasn't always that way. And I think it's in evolution as we speak. It can't really evolve fast enough, frankly, at this point. But I'll talk a little bit more about that. Let me start by showing this picture. So the guy on the left is Stan Dudrick. So Stan Dudrick is without question the most famous surgeon I'll ever know. Well, and you guys probably don't know who he is, but Stan Dudrick invented TPN. And along with that, like indwelling central lines. I mean, just, Stan was really an incredibly accomplished person, and his wife Terry was great. When Stan was a young surgeon in the 60s and 70s, he didn't expect to be home in evenings. He didn't expect to be home on weekends. He expected to work on holidays. But importantly, not only did he expect it, his wife expected it, his kids, his colleagues, his neighbors, their extended family, the community at large. That was the expectation for people. Like if you were going to become a physician, this was the work. And you didn't have tension with missing things at home, or not as much, because there was no expectation on your part or anybody else's that you would be there for those things. That's changed profoundly. Even by the time I was, a young surgeon. And certainly, the picture on the right, me with some of the physician leaders down at Bridgeport a couple of years ago, it's changed. It's changed for us, and it is incredibly hard, much harder on the women. Right, society expects, not only are you going to be at the school concert, you're going to bring brownies. I mean, I don't know. There's just really unrealistic expectations, and it sets people up to struggle, unfortunately. And again, I don't think that probably gets enough attention. The work, every time we think we're making progress, something like COVID happens or the Cures Act, and that boulder rolls right back down the hill. I want to assure you, we have really good people trying to make the work easier within the health system. Like, we spend a lot of money on it. And again, they're good people and they're smart and they're working incredibly hard. And, they're going to keep doing it, and we're going to keep having them do it. But it's going to be a long time before the work gets a lot easier. I don't want anybody to be under the illusion that we're not trying, but I also don't want you to have the illusion that it's going to get suddenly a lot better next year. It's not. It's a struggle. It is a struggle. It'll be a struggle probably throughout your career. Certainly it has been through mine. I talked about resilience. So Steve Southwick was a professor of psychiatry here, did a lot of time at the VA. Dennis Charney was also a professor of psychiatry here, although he is now, I believe, the dean at Sinai. Yeah, Howie's nodding, so I must be right. Two very smart, dedicated guys who wrote a book about the science of resilience. If you are interested in the science, I'd urge you to buy the book. It is not an easy read, because it is about the science of it, but it's worth the read if this is a topic that is of interest to you for any reading. Man's Search for Meaning by Viktor Frankl, I think, is a book everybody in the world should read. So if you've never read it, buy it. I can't give you a stronger recommendation than that. So just buy it. Get a perception of, people going through incredibly difficult times, getting through it. A couple of the books are, modern kind of views on Stoic philosophy, and then the Enchiridion and meditations are, kind of classic Stoic philosophy, which I ascribe to. So Steve and Dennis kind of characterize 10 categories of things that help people with resilience. I'm not going to go through the list, but again, be aware there is actually science around all this, and it is worth spending some time reading it if you have the time, or when you have the time. Culture's tough, right? Everybody says, culture eats strategy for lunch, and culture is really slow to change. Yes, I don't disagree with that, but it changes. I have two great examples. So when I was a surgery resident in the late 80s and early 90s, M&M conference was brutal. I mean, it was, why did you kill this person? Or, Dr. Ivy, I've been a surgeon for 20 years. I've only had that complication once. You've had it twice already. Real personal attacks on residents and occasionally attendings during M&M. Now you listen in on the surgery M&M that John Morton runs. That's all about the system problem. What can we do to change the system to make this less likely to occur? It's so changed, it's almost unrecognizable. So, and people believe that's the way it should be done. It's not like, we're forcing the change in the agenda. Like, there's a belief that that's the right way to do it. It's a profound change. And then resident work hours. Again, so when I was a surgery resident in the 80s and 90s, if I had said, I don't want to work 36 hours in a row, they would have said, go into pathology, right? Or go into something outside of medicine. Do not be a surgeon. And they would have thought I was weak. Like the attendings, my fellow residents, I personally would have thought I was weak. I talked to my daughter. She's like, that's crazy. And I think that's the real genuine belief amongst residents, and a lot of the faculty now is like, working more than 24 hours and maybe even more than 12 hours is just crazy. And it's not good for you. It's not good for learning, and it may or may not be not good for your patients. So there has been fundamental shifts in the culture. I mean, we got to be able to change the culture in less than 30 years. I'm not arguing with that, but the culture does change. And so I think part of why I'm giving this talk is the culture around depression and suicide and healthcare needs to change. And it's not going to change if people don't start talking about it. So that's why I'm here. Let's see. In contrast to burnout, depression is an illness. Although some people with depression take offense to that, I think of it as an illness. You don't cause yourself to be depressed. You don't even really realize you're becoming depressed until suddenly you've been depressed for a while. You don't have control over the onset of it. Burnout may be a risk factor, it may not be. Personal history is a risk factor. Family history is a risk factor. Certain chronic diseases are risk factors, social history. So there's a lot of things that are risk factors, but it is a disease, to be clear. We are lucky that suicidal ideation and people dying from suicide is much less common, although it is still arguably too common, inarguably. Again, here's some evidence on depression in physicians. Again, I'm going to use the Medscape data probably because it's not I mean, you know, they've taken it seriously now. They've been doing the survey now for a number of years. So it's showing something. The burnout rate's probably over 50%. About a quarter of physicians seem to be suffering from depression. Shanafelt, this is a survey that was the survey he's reporting on was done before COVID, but about 6.5% of physicians, that included a mix of attendings and trainees, had thoughts of suicide in the previous year. So it's a lot. The Medscape survey, again, peaked back in 2020. Right now, it's probably about 10%. It probably varies a little bit by specialty, but it's high across the board. So we need to recognize that it's an issue for us. I mean, if 1 in 10 physicians is thinking of taking their own life, that deserves attention. We should be talking about it. It is not a new problem. So this is a consensus statement that was published in JAMA back when I was struggling. I mean, it's 20 years ago, literally. I bolded one of the names, Wendy Hansbrough. She is the wife, or was the wife, of Dr. John Hansbrough. So Dr. Hansbrough was the medical director of the burn unit at UCSD, where I rotated as a resident. He's a brilliant guy. And I don't use that phrase for a lot of people. I'd use it for Howie, not a lot of other people. Really. Dr. Hansbrough was brilliant and funny, very dry sense of humor. But unfortunately, he ended his life in 2001. And I want to quote something his wife said in an interview a number of years later. She was being interviewed about healthcare workers and suicides. And she said, "My husband didn't die from suicide. My husband died from untreated chronic depression that the culture of the medical community refused to acknowledge exists." We got to change that. Got to change that. Hence this talk. So I'm going to talk about my journey, probably more vividly than you're used to hearing. And I'm going to be very honest about it. I'm going to do it for 2 big reasons. Well, 3. I want to change the culture. But partly within that is I want to let most of you are not depressed and will not develop depression. That's the good news. And I want to give you some insight into how someone who is depressed thinks and feels. And I think it'll be helpful for you to have that insight. The other group of you have struggled or are struggling or will struggle. And I want you to know a couple things. 1, you're not alone. And it's okay. And it's okay to ask for help. It's okay to take care of yourself. Okay. Again, I've given the talk enough. I know there are people in the room or on the call who are struggling. And it's okay to ask for help. So this is me. I'm, I don't know, 5 or 6 probably. I'm wearing a bow tie. This is in enlisted Navy housing in Groton, which is about an hour east of here. My dad was a submarine sailor. So he spent almost exactly half my childhood at sea, which means my mom raised us with a lot of love and care. My mom did suffer from recurring bouts of depression, unfortunately, but we turned out okay. And as Howie mentioned, went to school. I joined the Navy to pay for medical school. This is me did my internship at the Navy Hospital in San Diego. I spent a couple years as a battalion surgeon with 3rd Battalion, 1st Marines and Marine Infantry Battalion. This is the most joyous experience I had during that deployment. This is a baby I delivered. There was a village right next to one of the training areas, and a woman went into labor in the middle of the night, literally in this bamboo hut. I had my Corma with flashlights on. I was, delivering this baby. It was great. Maybe I should have gotten an OB, but there's real joy in delivering a healthy baby. So after I did that, after I spent time with them, I went back, finished my general surgery residency at the Navy Hospital in San Diego. And then, let's see, this is me as a chief resident. You can tell I'm old because eyewear protection was not mandatory. You'd never see a picture like that now. So after residency, I deployed in the Mediterranean, in the Adriatic, came back, got out of the Navy, came up to Yale, that's how he said, did my surgical critical care fellowship at Yale. Was here for a while in kind of a joint role with Bridgeport and Yale New Haven. And then kind of switched and was employed by Bridgeport, and still was doing a little bit of both places. By 2001, I am a really busy acute care surgeon, and I love the job, right? There's no part of that job I didn't love. I love the trauma. I love the emergency general surgery. I love critical care. I love burns, right? I love the elective surgery that I did. Teaching the Yale surgery residents, again, and I know that this is true with your department as well. Yale residents are selected for their ability to learn. Like you are all great learners, right? If I can't teach a Yale resident, then I'm a terrible teacher. So I would get, a number of teaching awards over the years because of that. I love the job. But then in late 2001, actually, so GME was undergoing massive changes at the time, which again, you guys were not really aware of, but there were big changes going on. And the RRC withdrew the accreditation for the Yale General Surgery residency, like pulled it. It's crazy. The new chair asked me to be the associate program director. That was a new position here at that time. And, originally there was going to be some protected time for me to do that. There was not. I gave up what little clinical research I was doing, but that didn't compensate really. So from January 2002 through the summer, I was working incredibly hard trying to get that new program accredited and still being a busy clinical surgeon. And we succeeded. In July, we got a letter saying the new program had been approved. We had like a day of celebration. And the next day, the chair at Bridgeport, Dr. Dudrick, announced he was leaving to go somewhere else. Like, okay. And normally that would have been, a good thing. Dr. Atway, who was the chief of trauma, became the chair. I became the chief of trauma, which had been a career goal of mine. But it just meant more work. And not only that, but so Dr. Atway, while he was great and continuing to take call, he couldn't do the coverage during the week like he normally did. And so, so it just meant more work for me and Dan and Phil. And pretty soon we were all burned out. I was burned out to start with by that summer. By the fall, we're working, hard. We're working like we're surgery residents again, like old school surgery residents. And like, it's fine. We're just burned out. Suck it up, because burnout was a thing in the trauma world even then. But we were still working, the old fashioned call and stuff. And so when I think back to how that was, I was constantly at work, which meant, I missed Little League games. It meant I missed ballet recitals. It meant I missed school concerts. It meant I missed dinner all the time. It meant sometimes I had to ask Phil or Dan, hey, can you take out this gallbladder for me? I got to go. And as I talked about earlier, like if you start to feel like you're not being effective and you start blaming yourself, I just blame myself for all of it. I felt like I was failing all the people who were important to me in my life every day. Every day I'd drive home and I felt like I was failing. And every day I came into work, I felt like I was failing the people I was taking care of. And I just wanted it to stop. And look, I'm good at solving problems, but I couldn't find a way out of this. The hospital couldn't hire more people. We were understaffed, and there was just all this work to do. And at some point, I lost hope that it was going to get better. I just lost hope that I was gonna figure this out. And then, and then you start to lose joy. You lose joy in what you're doing. I mean, I don't know. Was I fatigued? I was fatigued anyway. At some point, the idea comes across, it'd be okay if I died. It'd be okay. And then it's not really a big leap from that to, this isn't actually going to end until I die. It's just a grind. It's just a grind as the months went on. By the winter there, at the early 2003, I didn't see any light. I was in a very dark place. And I just wanted it to end. And so, I'm a trauma surgeon. I'd seen a lot of people die. It wasn't hard to come up with a plan on how to end my life. I did not, every day I would come to that time of the day where I would either act or not. And, I would decide to keep going because of my kids, right? I had 3 kids. I had known some kids growing up whose mom had died from suicide. I just wasn't going to do that to them. It's awful. I mean, it was hard on them. I just wasn't going to do that. And, but it was pretty much a struggle. And I think maybe one day when maybe I came a little bit closer than some of the others, I'm driving across the Q Bridge, and I have this kind of epiphany. I remember a lecture from medical school where the psychiatrist says, when you're assessing people for depression, you need to find out if they're thinking of harming themselves, and you need to find out if they have a plan. Because if they have a plan, it becomes very urgent. Because then you're just an impulse away. And I mean, I know it's hard to believe that at some level, it's hard for me to believe that I had been suicidal for a couple of months at that point. And that was the first time I was like, oh, I'm depressed and suicidal. Like, I need to get help. I'm not going to get better. I can't, wow. So, so we actually covered the VA as well at that time. So I went into the sick queue at the VA and rounded, and then called Ronnie Rosenthal. Maybe you know her, maybe you don't. Ronnie is just a great human being, and she was the chair of surgery at the VA at the time. And I said, hey, Ronnie, I'm struggling. Can I come up and talk to you for a few minutes? And Ronnie's great. She's like, yeah, Mike, come on up. I'll make time. Come on up. And, I pretty much broke down. I don't really recall much. I have no idea what I said. I don't remember much of the discussion. And I went home. I took a couple weeks off. She found the name of a psychiatrist for me to call. And I started seeing him. But I left. It was the first time I had hope. that things get better in a long time. And so, so I started therapy. Therapy worked for me. It really did. I mean, like I gained a lot of insight. It helped me think more clearly for the first time, and I don't even remember how long. I'm prone to ruminating, like no doubt some of you are. Like I understood, like if I start ruminating, I got to stop. Like, stop, distract yourself, think about something else. It doesn't help you. So that was therapy was life-changing for me. We made some changes at work because I was able to think a little bit more clearly over time. And and again, therapy and medications, they don't work that way. It's not like boom, you start going and you feel better. I mean, it was months. But I really started to feel better and really started to think better. And we changed things. We stopped going to the VA, which I regretted, but that wasn't our responsibility. We stopped taking call. We stopped doing 36-hour calls. Like the residents have been going home at 8 a.m. for years. Like we're still working all day. Like we started going home in the morning after call. We stopped doing almost all elective surgery, unless it was coming in through the primary care center and being referred to us. Like we stopped doing it. Like which is what allowed us to go home post call. But so we changed the way we worked, and it did ease things. I continued on for another year, but then I went up to Hartford. I was the vice chair up there for a few years. Came back to Bridgeport as the VP for quality and risk, as Howie told you. CMO. I mean, here I am in this role. Like I've had a great career, and I want to emphasize the depression changed the arc of my career. Right? I never became a chair of surgery. I never went kind of in the path that everybody would have predicted for me. But like therapy saved my life, or at least saved my career. Maybe I wouldn't have, acted, but I wouldn't have gotten better for a long time, if ever. And so, I think it's important to kind of acknowledge therapy works, and it helped me, and I got help better because I got help, period. So what went wrong with me? I think there are a bunch of risk factors that come together. Family history. I think I mentioned my mom had depression. If you have a close family member with depression, you are at risk. I never thought I was at risk. I mean, like I'm not at risk. My mom's got it. That's not me. No, if you have a close family member who has a history of depression, you need to be aware of your risk. Chronic disease. I've been diagnosed with ankylosing spondylitis in the 90s. It's non-radiographic, sorry. And the arthritis is not that bad. I mean, it was bad the first couple of years, but it really eased off. By 2001, it wasn't as bad. But the uveitis in my left eye was not fun. And it just seemed like it would not settle down. And I went up to Hartford, and I was only taking a couple calls a month, and it would get under control, and then it would come back. You're like, that was really better. What happened? And then suddenly, like at one point after being there a year or so, I was like, oh, it's the call. I take call Monday, like, you feel bad on Tuesday. I feel up all night Monday. But like Wednesday or Thursday, like my eyes start to hurt. So it was a delayed thing. So, it took me a year. So my first response was like a real surgeon. I'm like, I'm going to suck it up. I can't give up doing trauma, because if you give up call, you're not a trauma surgeon. But after sucking it up for about a year and a half, I'm like, okay, I'm done. I give up. I can't do it anymore. And I tell that story to make the point, like life happens. Life happens, and sometimes you have to change your plans. I don't know, it is what it is. Don't let it devastate you. You change plans. It's okay. Stress at home. One of my kids has some chronic health issues. And so, that's a real stress as well. And again, you may well need, depending on, if you have a kid or a spouse or a parent who's ill, really ill, you may need to change your plans as well, and be open to that. It's okay. This is part of the story. Stress at work. I think, so I put this up here more because, there's this connotation that if you're depressed, you're failing. And certainly that's the way you feel, right? You feel like you're failing. But you look back at my career in the early 2000s, I was a really busy, successful acute care surgeon. I was the associate program director for the Yale General Surgery Residency. I was the chief of trauma at Bridgeport, which is a level 1 back then. You know, I went on to run the board review course for the Society of Critical Care Medicine. I wrote a landmark paper on burn shock resuscitation. I mean, because you're depressed does not mean you're a failure. So if you are feeling that way, don't feel that way. That's not what it means. Why is it hard to get help? Well, like it took me forever to recognize a mill. You guys are hopefully smarter than I was, but it can be hard. And you're not going to recognize it right away, right? You have to be depressed for a while before you realize that's what it is. You just feel bad. And you got to admit that you need and deserve help. Both parts of that. I don't know how I could have done it without talking to a friend or trusted colleague. Ronnie was really both. I don't know how I would have been able to find a psychiatrist on my own. I don't know that I could have done it. So I encourage you to try to find somebody to talk to. And if you're the person that they come to, don't try to navigate the mental health. It is very complicated. But there are people, if your residents, Andy Asnes and Steve Hewitt are great people and they will help you navigate it. I promise. They're great people. Dr. Butler, one of the attendings, is when oversees wellness for the department. I guarantee if you're an attending or faculty, she'll help you navigate it. So will Rob, so will Howie. And there are people who will help you, please. Just Sam Ball from the Yale School of Medicine. Like there are people who will help you do this. But be empathetic, listen to them, but again, get some help if you're going to try and navigate it. Then you got to make the appointment. Even though you got to get help, you got to make the call or you got to go to the ED. I mean, again, it really feels like you're admitting that you're flawed as a human being, and you're not. Right? You're just trying to get help. Like it's like if you had asthma, you're just trying to get help. Then you got to go. I remember pulling in the parking lot and parking the car and walking to the door and going up the stairs. I mean, these are the moments that you remember. It may help to have somebody bring you. I didn't, probably should have. Then you got to open up. Like who wants to open up and who wants to go to some stranger's office and cry for 45 minutes? Yeah, not me. Not me. That was really hard. Right. And again, in contrast to weakness, like it takes incredible strength to open up like that. But therapy only works if you actually open up. You got to take your meds and continue your therapy. You will feel pressure to do both, to stop both. One, the meds change the way you feel and think. I mean, it's variable amongst people, but commonly and people, I don't want to take it anymore. Please give it some time. Give it some time. And then you got to continue the therapy too. And it takes a lot of time and it's hard. And people are like, oh, you don't have to go because there's this whole stigma. Oh, you don't really like, no, like if you're there, you need it. Reserve the time, make the time, go take care of yourself. It's important to acknowledge depression can be chronic. It is very commonly relapsing. And if you've been depressed, you're gonna, find times where maybe you don't go all the way into depression, but you struggle. Again, that's okay. Just, just keep going. Take care of yourself. You don't have to be suicidal to benefit from somebody. So when I was a third-year student, chief resident in our psychiatry rotation said, everybody's got a problem they could talk to a counselor about. I want you to make an appointment and go talk to a counselor about a real problem. Holy cow, that is hard. Even when forget about when you're depressed, but even when you're feeling good about life, like that's actually a very hard thing to do. And if you've never done something like that, I would encourage you to do it. We criticize people with mental illness for not going in and not taking their meds and not doing stuff. Find out how easy it is. It's not a chip shot. So here's my advice. Again, a series of slides about advice I have for people. exercise. I mean, how many papers need to be written? Exercise is good for you. At least 30 minutes, 3 times a week. I don't care if it's walking the dog, kayaking, running, swimming, riding a bike, doing Pilates, doing yoga. I don't care. 30 minutes, 3 times a week, more if you can. It's good for your heart. It's good for your lungs. It's good for your skeletal muscles. Many exercises are good for your bones. It's good for your brain long-term, and it's very good for your mental health in the short term. So make the time, please. Get enough sleep. Yeah, we don't sleep enough. Please, and I get that, the jobs can make that difficult, but try to get the sleep that you need. I think it's important. And eat well. I try to find things to be grateful for every day. I think that's important. A grateful attitude is a big deal. Anybody see the sunrise this morning? Like spectacular sunrise this morning. You got to take a few minutes to notice those kinds of things. Please, again, I'm not talking world peace. I'd be grateful if there was world peace, but I'm going to settle for things like the beautiful sunrise. Okay. It helps me. Here I am walking my dog. It helps me to walk, to hike in the woods, on a field, wherever, just to get out, be away, once a week at least, spend some time. This is my first grandson. My second one was just born, I'm happy to say, this past Saturday. So Oliver says, be compassionate towards yourself, right? Don't just cut yourself some slack. I will go so far as to make a bold statement. No one in this room is good at self-compassion. You've all driven yourself really hard to get where you are, right? Cut yourself some slack. And if you find yourself ruminating, focus on the moment. Focus on what's enjoyable with you, like smushed peas, apparently. But just focus on what's important, okay? And let the rumination go. Stay connected to your loved ones, right? I can't tell you how important that is. You got to have support outside of work. You also got to have support in work. So be very intentional about getting together with colleagues. You don't have to be in radiology. You can be in whatever department you want, but physicians, we bear unique burdens that non-physicians may not understand. So you need to be very intentional about having colleagues that you can talk to and spend time with. Okay, it's for your mental health. That sense of connection is really powerful in decreasing your risk for burnout and for depression. Get involved. Don't get over involved like I did, but some involvement is a really good thing. Okay, some degree of it empowers you. Like, there was this problem with blood transfusions, and I got involved in this committee, and now it's better. Like that's one way to feel better about yourself and about work and about life in general. So get involved. Just make sure you don't overdo. This is a picture of Ronnie Rosenthal back in the day. The more recent one was too grainy. So anyway, this is Ronnie. If your friends come to you or your colleagues come to you, like, be empathetic, and then get in touch with somebody like Andy Asnes, right? Sam Ball, whoever. They'll help you navigate it. Rob Goodman, Howie Foreman. But your job is to listen and be there and show some empathy. My advice for those of you who think you may be depressed, don't wait as long as I did. I should have known. If you're struggling, it's okay to reach out earlier, right? You don't have to wait. I mean, if you have thoughts of harming yourself, you need to reach out. And again, if 1 in 20 or 1 in 10 physicians are having thoughts of harming themselves, that's a lot. And again, I know that I've given the talk enough now. I know that there are people who are struggling with that. And maybe you start talking with a friend first. I should probably put the suicide hotline on 988, but I mean, you can always talk to somebody. And whether it's you're a system employee and it's EFR, or a university employee or it's EAP, there are lines where you can call, where you can always get a hold of somebody. Always. So this is my daughter Julie when she graduated from Case. So Case has this great tradition where if the graduate has a relative who is a physician, the relative gets to hood the graduate. Oh, dude, I mean, that was a great moment. Sublime, I think, is how I've referred to it. It was transcendent. I don't know. It was a great moment. And I was incredibly grateful to be there for it. Most days I'm not that grateful, but I have a lot of things to be grateful for in my life every day. And so do you. So try to reach out, please. I'm incredibly grateful to be here right now, frankly. As I said at the start of the talk, it's a real honor for me. I have enormous respect for Howie and your department, and very much appreciate this opportunity to talk to you. Okay.